Hello, and welcome to the MedFlow webinar series, Inside Primary Care. I'm Dr. Ritwik Swain, a clinical AI researcher. In this series, we speak with healthcare leaders about the realities of running modern general practice behind the scenes. I'm delighted to be joined today by Dr. Sahadev Swain, general practitioner, as well as being my father. Dr. Sahadev brings valuable insights into the challenges and opportunities facing general practice today. We'll discuss the joys and the woes of running a GP practice, covering themes like workload, compliance, governance, and operational management. So, Dr. Sahadev, Dad, thank you for joining us today. So,
Thank you, Ritvik. Thank you, Ritvik, for that kind introduction. I must say thank you, Medflow, for giving me the chance to be the to start on this important project.
great. And we want to start off by asking you what originally drew you to medicine?
Oh, that's a long story. I'm only 65. Go back 60 years where I came from. Came from a, you know where I came from. You have been once to a very remote village in a state called Odisha in India. That was the area which was surrounded by rivers with very little access to outside world. There was about 2 lakhs of population served by a very benevolent doctor. He was my role model, and I quickly saw from my own illness and that of illness around me that this is something is very noble. This is what I want to be.
Mhm.
And Dr. Divakar Nath Sharma was my role model. I almost thought I must, oh, this poor man has to cover so much. I must help him out. So I must do medicine, come back to the village and help him out. I started with good intention. I did become a doctor, but
Mhm.
unfortunately, I could not go back to my village. I
Mhm.
now live in another village in another country.
Mhm.
That's a different story.
Indeed, and I know that you started off originally specializing in obstetrics and gynecology, and eventually decided to move to general practice. What made you, go for this transition?
Yeah, I obstetrics was my first love. Imagine the time of stepped on Edwards when the first test tube baby was coming. And obstetrics gynecology appealed to me. I always wanted to go into academics, become professor of obstetrics and gynecology, to provide a good women's health care. Those were days that there was little of medicine, a bit of surgery, not very many operations, but you could do quite a lot of good. You sort out the woman in the house, you sort out the whole family. And because I had a gold medal in obstetrics and gynecology for securing highest marks, those are the prerequisites for becoming a lecturer those days.
Mhm.
So I wanted to pursue a career. I did masters from Banaras Hindu University, where I taught in Jitmara, Pondicherry. I got a Commonwealth scholarship to do further studies. Then, as it happens to a lot of immigrants, you come with 1 year plan, and that 1 year changes into 5 year and then to lifetime. So that was a time I wasn't having career progression here. So I chose alternative careers
Mhm.
where becoming a GP was becoming attractive that time. You don't have to do on calls. At the time, something called quality outcome framework came into existence. That means you could do much more than the GPs used to provide and be paid for it. And I could have chosen to become a middle grade to some other person for all my life, almost signing up to slavery. But I wanted to be me. My name should be in front of my
Mhm.
room.
Mm.
and I should be working with people rather than for people. That's how I changed general practice. And I think it was a good choice. I've never looked back.
Yeah, interesting. So you wanted the career progression, but also the ownership and independence, I suppose, of being a GP. And of course, you've been a GP partner now for decades. So, what did becoming a GP partner rather than a salaried doctor really mean in practice beyond just a title?
Yeah, the very lot of public do not know GP practice is a business.
Mhm.
You can say it's a corner shop. Um, I am not a government employee. As a GP partner, I am a government contractor. So the government pays certain amount of capitation money to run my business, provide the service,
Mm.
employ my own staff, and so and with other partners, I own the business. So that ownership, that independence matters quite a lot. That gives you freedom to become innovative, and so which will not be there if I am a salaried. So
Mm.
that attracted me to be, and then I always, as I said, I always wanted to be academic. So I was able to become a trainer, and we train registrars to become GPs, and my academic interest also. I kept on becoming seasonal or freelance teachers to medical schools
Mm.
like Cambridge and UCL or Royal Free.
Okay.
So that was the advantage of becoming a partner.
And then, so yeah, there was a yeah. It sounds like lots of flexibility, independence again. But then, when you became a partner, were there things that surprised you about, yeah, the business side of things of running the practice?
No, the business did not surprise, but things just come to you. Some
Mm.
of my senior partners has got a kind of weird sense of um, delegation. So, walking on the path, my senior's partner says, "You are in charge of prescribing." Looking at it, they have been prescribing hundreds or 100,000 more than they should be allocated. In the same way, one day you'll say, "Oh, you are in charge of finance." Sometimes I thought I became a doctor because I could not know much of maths.
Mm.
Now I'm in charge of finance. But in general practice, in the vocational training, it trains you so much that you could excel in anything if you put yourself into it. So even in that finance business, I realized soon that they were working long, hard, earning a lot of money, but had no time even to calculate or count. Accountancy wasn't up to date. So just by making it up to date, I realized that one partner was overdone by nearly 100K than the junior partner who continued from becoming a salaried a partner. So those equality was brought quite quickly
Mm.
and efficiency was brought into the system. So yes, it's tough. It is learning on the go.
Mm.
I always enjoyed. I've been a lifelong learner. I always enjoyed learning and earning rather than just earning. Yes, money motivates a lot of people. It should motivate me as well because I have been poor. But learning has motivated me more because that leads to personal progress. And also, if you are a teacher, you you teach, you bring changes to people's life in addition to becoming doctor, healing them or making their life better. So on a good day, I enjoy my job. It's one of the best job in the world, and I will not do anything else.
Ah, that's great. So it sounds like there's lots. I was going to ask you what's your favorite part of being a GP partner, but there seems like there's many favorite parts, like the teaching aspects and the lifelong learning. Anything in
Yeah,
specific?
Like you said, I came to general practice. Half of my life spent, um, yeah, if I correct myself, I have been GP maybe for 40 years, sorry, doctor for 40 years and GP for 20 years. So half of my life was women's health and or running up to it. So I thought I could bring that
Mhm.
challenge to the community, which in to great extent I have been successful in. I collaborated with the company. I came with a grant and I started what we call as the one step or one stop menorrhagia clinic, where women could be assessed with heavy bleeding, could be assessed. You could organize the ultrasound scan, which I could value, and then even necessary, you could take a biopsy all in your office, and they go
Mm.
to hospital only if they need an operation. So that was women's health was my first kind of interest. But I realized as I grow, my interest changes.
Mhm.
At this moment, we could talk it later. I'm very much interested in something called social isolation.
Okay.
And I've just started a pilot clinic. Uh, to my best knowledge, is probably first in the country where we could talk about a bit more. But what I'm trying to say is that my passion or interest also has changed as
Mm.
I advance in my journey.
Okay. Thanks for that great answer. So it's yeah, it's not always the same. And yeah, so moving on to maybe some of the more challenging sides of running of being a GP partner. So what are the biggest pressures on a GP partner today or practice today that patients don't see?
Yeah, to be to be honest, the health challenges has always been there,
Mm.
as far as we can go back. As it happens, in preparation for this interview, I was reading a bit, and I came across a letter to the editor in the BMJ in 1964, maybe just 2 years after I was born. And the tone and the problem and the complaints are not very different what we are facing it today. However, the things have changed sometimes, most of the time for better, and sometimes it has become more complex. If we have to look at the NHS in the UK particularly, the 10% of budget of the whole of NHS is related to general practice. However, 90% of the transactions happen in the general practice. They say general practice is the jewel in the crown of NHS. This maintains the cost effectiveness of the whole of NHS. Health is a costly business, and NHS is a victim of its own success. So successful we have been, people are now living much nearer to 100 and the problems that goes with it. So, however, we have always strived to make it cost effective
Hmm.
and solve the problem. As it happens now, we are going through a lot of changes in technology side. And the politicians, being politicians all along, probably sometimes enhance the expectation of people rather than solve the problem. It's always a spin into it. Sorry, I'm saying this as a citizen rather than of any organization I'm talking of. What I mean by that is our health minister or outgoing health minister may say that the waiting list has come down, etc., etc. The statistics it could be spin as better, but after the corona, the waiting list has gone up very high. Even today, if you go to the hospital, there are elderly people in the corridor being treated there. And I have experienced it myself because I have been a patient recently
Hmm.
in the hospital. So the challenges are more. If you look back for the UK, the growth has not been to the extent that we spend in the public services. So therefore, always there is deficit. And last 20 years, I think, most of my life has gone in what is called austerity, in trying to save money, including pennies. Say, don't give paracetamol to your patients, don't write creams that they can buy, etc. So money has always been tight because we need much more money for the NHS. NHS is a cooperative system where some people, healthy people like you, will not visit the GP, whereas women who are having children or elderly people who are like me, 60 and above or 65 and above, will go more often. So that is how it is a cooperative social institution which is and the care free at the point of care. However, we have increased the demand. You could see your GP anytime you like, any way you like,
Hmm.
and the 90% of the problems to be solved on the same day, although it is solving some problem of access, is creating another problem of stress on doctors, on practice managers, and on reception staff as well. So
So,
change has been always constant, and the staff and everybody else
sure,
is responding to that change.
sure. And well, let's try and maybe focus down on like maybe everyday practical matters. So, what proportion of your time, for example, would you actually spend with patients on clinical care versus operational and administrative things as a
As
GP?
the time has gone on, okay, to answer that question, I'll tell you a story. When I was training, I was the first brown man in an English village as a trainee. But the GPs came at 8, by 12 work is done, and they went on the way, did a visit and went back and had their food or maybe siesta or took dog for walk, came back at 3:30 or 4, another 1 or 2 hour surgery, 6, they're gone home. Okay. But now when I go in at 8 or 9, I don't finish till 7 and hardly any time left for having a lunch. Lot of after seeing patients, a lot of paperwork, referrals, prescriptions, administration, meetings to go to, and respond to hospital requests from colleagues, safeguarding, you name it, and preparation for quality improvement, your own appraisal,
Mm.
audit, teaching, supervision, and the challenges are umpteen. So maybe if clinical work is say 60%, 40% goes in non-clinical other work.
Mm. But yeah, so out of all the non-clinical work you do of the 40%, well, I mean, some of those things sound like things that you that where your input as a doctor is valuable, whereas other things perhaps are could be no more manual or repetitive things that didn't they don't always need your input. Is that fair to say? And to
And
what
that's fair to say, and
extent?
GPs are very good at delegation as well. Until now, it has been delegated to other people who can do it, including salary GPs, trainees, healthcare assistants, nurses, minor illness, to practice manager, secretaries, or your reception staff. but the delegation comes to such an extent that everybody is overwhelmed with that. So that is why probably because, as you said, we are in the age of AI or automation. Some of the jobs can definitely be automated by use of AI, so long as we are using what I call OI, own intelligence.
Hmm.
If you are doing it intelligently and diligently, it is a very important tool. And of course, it can come. There can be mistakes. We should be careful about it. We should
Hmm.
be vigilant about it. There is ethics involved, and there is risk involved in it. However, um, we should every little help that we should take to make the life of receptionist or the practice manager or the GPs easier
Hmm.
perform the duties efficiently. They should have the resource and the time for delivering a good and efficient, proficient, and kind care.
Hmm. Thank you. So yeah, very important indeed. So are there certain tasks right now that are especially repetitive and manual that that where there's the biggest opportunity for automation to help GP practices?
Yes, I think it could happen at all the levels. Okay, the jobs. If I start with, say, from GP, from GPs, as I said, we have to, there is plenty of letters coming from all along, from hospital, from district nurses, from specialists, from mental health, from secondary care, tertiary care, and from patients, um, and other agents, insurance company. So uh, nowadays it's possible that it can be automated. So the AI would read the letter, highlight the accents, read code the conditions so that if there's a new diagnosis, for example, diabetes, it has to be read coded so that the ongoing care can be taken care of.
Hmm.
So these are all possible. Now systems are available for doing that. That's an example. And we always focus on GPs in in the general practice, but not to forget, practice managers are the kingpin of the corner shop that I said. They are holding on to the door from all the sides, managing staff, managing doctors' conflict, managing increasing level of complaints. Now, even the AI is also a culprit for encouraging people writing the complaint letter easily. You just give a few words, so ChatGPT is giving you the complaint letter is easy to pass on. Before people thought through for a long time, now people don't have to think about it. Some of them are very trivial. Of course, complaint is a good system for feedback for quality improvement, but sometimes it is also, dare I say, that it is nuisance and wasting time. Some people are good at it and at the cost of others in a way. If I'm spending hours in answering a complaint, that hour can be used to somebody needs that care most. So although it's a good instrument, but it has to be used judiciously.
Hmm.
And
Indeed.
so at the practice manager level, they have to manage the rota, who is going where, they manage sickness, and then also um, nowadays everything is quality control. Our quality control is called CQC. They could visit you at any time unannounced,
Oh,
and
oh.
you should be ready from all point of view. And it's a loads of preparation. How is your clinical care? How is your leadership? How is your communication? How do you deal with your vulnerable patients? And how do you manage prescription safety, etc.? So those are those ultimately falls down to the practice managers.
Okay.
And I don't think doctors have got a body like local medical committee or British Medical Association. I don't think practice managers have. They have very little peer support, so they are getting on with it. And there are a lot of ill health there which goes unnoticed. So if we keep our practice managers happy, or by allowing some certain of good automation,
Hmm.
will also create a space for better patient care at general practice level.
Okay. So it sounds like, yeah, practice managers are taking on a great burden of um, yeah, keeping the ship running,
Of course,
and yeah, like so automation could help them as well, but also perhaps some sort of guild or association that will help with yeah, networking among themselves, so that yeah, they feel that they can support each other.
they feel supported. Yes, I think what doesn't go notice, is goes without saying that a happy workplace increases the productivity. So we, even as a small GP surgery, strive towards that. Small little celebrations, permission for that, or going out for celebrating iftar, because a lot of our patients and workers are uh, belong to Muslim community, and then or going for a Christmas meal. All these matters, and sometimes celebrating that success and appreciating how hard they are working. It creates a good happy workplace,
Hmm.
good bonding among each other. I think is very important. I don't think NHS gives importance to that.
Okay.
Sometimes I jokingly say we all love NHS, that's our religion, but I'm not sure NHS loves back their employee that much.
Mm.
But it may be very generalization. There may be some exceptions somewhere, but that's my general impression. We could do more. If we support our employee, they will be more productive.
Okay. And thanks for that. And then you mentioned as well the challenges with CQC and compliance. So, do you think there's an area that practices feel most exposed to or at risk when it comes to compliance?
Well, as I said, the practice manager has got umpteen job descriptions. I don't think I would like to be a practice manager myself. So, CQC preparedness is one of them, and it's an important ongoing job. It includes a lot of things. Is your employment up to date? Is your vaccination of your employees up to date? Is there a CRB check, like is every 3 years? Are they up to date? Are you managing your rota well? Are you giving right? Is your protocols in place? What do you follow when things go wrong? Or are you learning when from the audit that you have done?
Mm.
So all these are very labor intensive, and it is ongoing. It's not one off. So that's where I think AI can help to a great extent. A rota management is a weather science almost.
Mhm.
It's changing all the time. You have made every preparation, and then suddenly one person goes up sick. So you have got two places to run to, and then there are 3 or 4 people in a holiday time, and then somebody goes up sick. So it's lot of juggling there.
Mhm.
So CQC preparedness, rota management, as I said, so those are also areas for the practice manager.
Okay, certainly. And So rota management seems to be like a real opportunity for perhaps some smart solutions. And
Yes.
so over your career, so yeah, it's you've been doctor for 40 years and GP for 20 approximately. So what would you say has been the technological change that has had the biggest impact on your day-to-day work?
Um, it's difficult to say. It's not only technology, the policy changes slowly. Say, for example, when I was joining, quality outcome framework was a big intervention where a lot of the things that was happening in hospitals, GPs were able to do and get paid for it. And then um, telephony. They used to phone in the analog system, hundreds of queue. Now it has gone like cloud-based telephony. And then, of course, this system of total triage. You don't have to be in the queue, fill up your form, what is the problem, and the senior doctor is looking at it and endeavoring to respond to it in the same day. And almost 90% of the emergency care will be sorted out. I think it's one of the biggest um, interventions and challenges.
So,
While
so not everyone might know what that is. So, what is that exactly? It's the some kind of digital triage system.
earlier, first thing in the morning, you picked up your phone at 8 o'clock that you want an appointment. But recently, we have been doing it for 2 years. Um, you don't have to phone. All you need to do is go online and fill up a form. My son has got fever, runny nose, cough. Paracetamol is not responding. He has got so he needs to be seen by the doctor. So like that, even your need for sick note, whatever is your need, is put into the request form.
Hmm.
And a senior doctor like me is going to go through all this list and decides who can be seen today, now, who should can be seen within the next 3 days or 7 days or even 2 weeks. So that has helped the access for the patients, but it also has increased challenges for the receptionist, for the doctors, and is making harder also to maintain the continuity of the care because uh, senior doctors' time is taken in that.
Mm.
So those are the new changes. I think that's one of the technologies or procedure or intervention that we are all coping to cope with, trying to cope with.
Mm.
But it's good for the patients. They don't
So for
have,
the patient, so it sounds like it's been a really impactful intervention, and it's made things more efficient, and
yes.
then patients are happier with it. But through that, the capacity maybe has increased, and therefore maybe the workload has also increased on the actual practice. Or
Yes, the workload has increased at every level of receptionist, practice manager, GPs, and it's like constant running of marathon. I always get kind of scared. It has got physical and mental health effect because
yeah,
we are all human beings. You
indeed,
cannot be running marathon all the time.
indeed.
So therefore, we need adequate resources and the time to do the job well. So you can automate and reduce the work, but you have to see the total picture of it.
So, what kind of GP practice do you think needs to exist 15 years from now?
Um, Look, whatever it is, the most important is the doctor patient relationship. The
Mm.
trust between the doctor and the patients is the most essential part of the general practice. Why it is cost effective, why it is satisfying to everybody. So long as we maintain that basic principle, then general practice will adapt to it. but it's going to be bigger practices, larger in number, many doctors working together, maybe specialists together, working in a neighborhood. And is I don't know if you have heard about Manchester model. Everybody coming to a smaller area, the mini Manchesters everywhere, looking
Okay.
at their health, employment, well-being, prevention. That is how we will remain meaningful. That's the future, actually.
Okay.
More of prevention rather than cure. That's how we could stay alive in a way.
Okay. So preserving the doctor-patient relationship, more prevention than cure, and Manchester. I think with the recent political developments, we're going to be looking a lot more to Manchester for a lot of things. So yeah, so we do have to bring it to a close pretty soon. Before we let you go, what advice would you give to younger doctors considering becoming GPs and GP partners right now?
I would advise that, yeah, general practice is a very satisfying job. It is not suitable for everybody, because sometimes you are expected to be in several places at the same time. You should enjoy what you are doing, no matter what it is, whether becoming GP or a specialist. I don't have bias for either. When they ask whether you want to be GP or gynecologist, either is good enough to you. Whatever it's like getting married to someone. You are going to spend life probably. It is something I want to live my life with, and so if that is that, then that's what you should be. You should be taking up. And yes, being a partner, you've got more independence. Generally partners are paid a bit more than the salaried, but now with change in the dynamics, that is also changing. And what is, like I said, I think what I enjoyed is my portfolio career, becoming a GP and then becoming a medical politician, ICB, CCG, and Royal College of GP, and being a medical teacher, both in my practice and in clinical schools. So those kind of mix. And I also have gone out to the community to be part of the community. So all these mixed career, or what they call a portfolio career, is going to be future that will keep you uh, happy. And it's important, your happiness should be most important thing, so that you can provide the care with compassion,
Mm,
with hope. So
yeah.
that's what I will give the advice. And it's always the changes around you will come and go, but there will be always patients, and there will be always doctors. And we all came to becoming doctor to provide compassionate care. So when you forget, go back to your original statement,
Mm,
and then you cannot go wrong. That will be my advice.
okay. Well, thanks so much. What a yeah, important, um, yeah, powerful message. Always remembering the compassion, the care, um, that should come first. So thanks very much for sharing your experiences and insights with us today. For everyone watching, we hope this conversation has been entertaining, informative, perhaps even inspiring. We look forward to bringing you more conversations with healthcare leaders in future episodes. If there is a topic or guest you would love to see on the show, leave it in the comments or get in touch with us. We would love to know and try to arrange that for you. Other than that, I hope you enjoy the rest of your evening. Thank you for joining us in the MedFlow webinar series, and see you next time.
Thank you, Ritik. Thank you, viewers. And thank you, MedFlow.